Ladies and gentlemen, welcome back to Virtual Life Academy Studio. I would like now to present Jørgen Berntsen. He's going to tell us a little bit more about AI and AI models. Jørgen, over to you.
Thank you so much for the introduction. So I'm Jørgen Berntsen. I'm head of the AI development in Vitrolife. So main responsibilities to do IDA-score models for embryo selection. And today I'll talk about the different AI models and how to make sense of these different models. And the outline of my talk will be first to introduce how should models be evaluated and how should we estimate how good a model performance is. I'll then focus on different types of AI models and finally a few words about IDA-score. But let's start with model evaluation. So actually that's quite simple. It's we have some very good guidelines for how evaluating how our models performs, and I think every AI models and every performance and publication that you see, they should report these measures. And it's called model calibration and model discrimination. Model discrimination is how good the model is in differentiating between a positive and a negative transferred embryos. And calibration is then how good does the model scores relate to the actual rates that we see in clinical practice. So let's start out with model discrimination. And usually that people then start to present ROC curves and talked about AUCs and so on. But actually I think we should try to get away from that because that's actually quite a complex you could say quite complex to interpret these curves. So actually you should rather focus on concordance, and concordance means that if you take a random positive and a random negative, then the model's ability to sort or to rank these embryos, that is really what AUC is. So as shown in this graph, you just take the positive and you take the negative, and then basically you compare how often is the model right. So actually AUC is not that complex. It's a lot of people think it is complex, but actually it is a simple measure. But what is maybe a bit more complex is then the actual value. The concept is actually quite easily to understand, but the value is where it gets complex. So what the first thing that you have to notice is that the AUC is calculated for the whole populations of all transferred embryos. It's not calculated for the individual treatments. And that means that because actually treatment is what is important. We want the model to rank embryos within treatments. But usually we won't have informations or several transfers embryos from the same treatment, so it's not possible to calculate for the individual treatments. So we have to do with the whole populations of transferred embryos. And then further complexity is that the value also depends hugely on the clinic. So you will have very large differences in the observed values. And I have some guidelines that I usually use. I would say that if we look on age, then we all know that there's huge differences between different clinics in age distribution. And if you have a clinic with a young population, then you usually have a uniform transverse blastocyst. The blastocyst would be high quality. You have a lot of nice looking blastocysts. So these embryos looks quite similar. So it's really hard to rank them or discriminate between those high quality, and then the AUC will get lower. That is in contrast if you have a clinic with a much wider distribution of age, then you'll have some good-looking embryos, you'll have some bad-looking embryos. And this task is much easier. It's much more easy to discriminate between between good-looking embryos and bad-looking embryos. So in this case, the AUC will be higher. So it's not like the model is performing differently, but it's due to the patient population. And actually, that's the case also when you look into different selection criteria. If you do biopsy, then also these different procedures tend to either have more uniform blastocyst quality or more widely ranged. And again, the more uniform quality you have, the lower the AUC, and the more diverse population, then the higher AUC. So that's one thing that you have to be aware of when you deal with AUCs. Then the other concept is the model calibration. And calibration is something where you talk about how well does the score correlates to the actual rates. And in this slide, I have shown data from the K2 latest clinic, where they group their different scores into 4 groups, and then they estimated how the rates, the live birth rates were in each group. And what you can see is you get a very nice correlation between the scores and the rates, and that goes also if you look on the different age subgroups. Within each age subgroup, you have a very nice correlation between the scores and the actual rate. And this is I think it's a very nice way to present your data because it's understandable, it's making sense in your clinic, that it seems to work. However, one thing that is difficult with this measure is that you don't get a number. You don't get a very easy way to see is this good or is it not as good. If you want to compare models, for instance, then it's very difficult to say what is one model better than the other one. That's more easy when you're using the AUC concept because here you can compare models. Here you have more a visual representation. But what is important is that you kind of report both measurements. You both report the discrimination and you pre-report the model calibration. So that should be done for all model. If you build it internally or test it internally, you should use both model types or evaluation types. So the second part of my talk was more to the differences between the AI models. And here you can train models on a lot of different ways. You can have a lot of different type of data and a lot of different type of models and outcome, the predicted outcome that you use. But what is really important in my mind is the type of the input that you use to these models. So let's go a bit deeper into the different types of input to the model. Then usually I would say that you have 2 categories of input. You have one type of input is the embryo data. That is what you observed for each single embryo. That could be morphokinetics if you're using time-lapse. It could just be a still image. Of course, it also could be the actual time-lapse sequence. That's one type of input. The other type of the input is the more treatment-based input. That is where you have information about the patient, you have information about the treatment, stimulation protocols, and etc. But let's take a look into the embryo data. So let's start out with morphokinetics and morphology. I think this is what we were using like 5 years ago. Then we were focusing on morphokinetics. There's been a lot of models being made. Vitrolife made the KIT-score models based on the machine learning and based on the morphokinetics and morphology. And these has, of course, some nice features. They are more explainable. It's easy to understand why does the model gives a score and what is the score actually based on. However, especially if you do your annotations in the clinic, then you have subjectivity due to the different people who's doing the annotations. So it has advantages, it also has certain disadvantages. If we then go to single image or static image, where you're only using one image for predicting live birth or fetal heartbeat, then you can predict based on that single shot, but you won't have a temporal information, so you will be missing direct cleavages, you will be missing multinucleation. There's a lot of different features that you are missing, so you're not getting the full information from the whole development of the embryo. Also, you have a huge risk of bias, and when I'm talking about bias, I think about bias, for instance, due to the different camera types. If you're using a Nikon in one lab and you're using some other Olympus microscope, then you have risk in having the model is learning differences between the different microscopic systems, and that is of course not what we want an AI to learn, but it's very good at catching up small differences in illumination, microscopy, or different objective types. So you need to be hugely aware of bias. There's also another bias that people often tend to ignore, that is the time of the acquisition. So, for instance, one clinic might evaluate embryos early in the morning, while other clinics would evaluate embryos later in the afternoon, for instance. And you'll have a bias between those two clinics, and again, the AI is extremely good at catching up small differences. So it would learn something that is specific from this clinic just by that they're using earlier evaluation compared to the later evaluation in the other clinic. So you have a lot of biases, and usually you can deal with them, but you have to be aware of them when you're doing your evaluations. And then finally, what I think is the best option for having embryo data, that is of course the time-lapse sequence. Here you have all informations from direct cleavages, multinucleation, speed of development, etc. You don't have a device bias because usually you're operating on just a single system, at least that's what Idoscope is based on. You only have the EmbryoScope Plus, so that implies that the system or the AI can't do all the shortcuts because it is only intended to be used on one single device type, one single microscopy type. Of course, you have the consistent evaluation and no subjectivity as when you're using the morphokinetics. Then if we talk about the treatment data, that is the other part. One thing was the embryo part. Now we are returning to the treatment level type. And here, including information about treatment, I know there's many, some includes treatment data, some doesn't include the treatment data. And I think one very good thing and one reason for including treatment information is that you get better prediction of the actual ongoing pregnancy or the actual live birth. However, one thing that you have to be aware of is that you won't get an effect on the treatment ranking, and most of these AI selection AIs, they are meant to select within a treatment. So it doesn't matter because the treatment, you have the same stimulation, you have the same age, and etc. So the ranking won't change if you are using treatment data as an input. The ranking will be exactly the same, no matter what kind of treatment data. So you have to be very aware of if a system includes that, because then what I would say is that the AUC, as I just explained, the simple AUC is just saying a positive, negative, how good it is at ranking. And that is very problematic when you report the AUC for the whole population then, because that AUC will not be represented for what is going on within the treatment. And again, the AI, embryo selection AI, they are meant to be predicting within each treatment. So if you read AI publication about AUCs where they're using treatment information, then be aware that this is definitely overestimating the performance of the model when you're looking on treatments. So that is exactly why IDAScore, when I'm now turned to IDAScore, that is exactly why we are using time-lapse. We get the full information, we are not missing any temporal development, and we are also not using treatment information because the focus of IDAScore is to predict or to rank the embryos within a treatment. Then afterwards, it's okay to evaluate how the IDAScore performs within different subpopulation with regards to age, just as is shown from the K2 data. But then, now that we have evaluated the model, then what is really then important is that we're using all these metrics that I just showed you on new tests. We need to test it on new clinics, so that's why we have focused extremely much on doing external validation or external studies on that. And we have published very many papers on that, and if you follow also the talks here in ESTRA, you'll see a lot of talks about IDAScore, how IDAScore performs in different clinics, both with regards to morphokinetics, but especially also with regards to live birth prediction, fetal heartbeat prediction, and also ploidy. So please read all the relevant publication that we have made, because that is really where you know how the model is performing it. And for me, it's hugely important that we have the documentation necessary to support that IDAScore is implemented in your clinic. So my take-home message is that all AI models, they should report those two measurements that I've been talking about, and that goes both if you do your own AI, but also when you're reading article. Please notice these two performance measures. And as I said, if you are using or you're planning to use an AI for embryo ranking, then you should focus on AUCs, because actually AUC again is a quite simple measurement. And then if you are to include treatment parameters, then that is problematic, or you at least have to be aware that there's this differences between including treatment parameters and not to include treatment parameters. I think that was the end of my talk, and if you have questions or comments, then please ask or come to me afterwards.
Yes, thank you very much, Jørgen. Any questions from the audience here about making sense of AI models? And as Jørgen said, if you have any more that you would like to take at the stand, please do so at the time-lapse section of our booth. Thank you for joining us. Thank you, Jørgen.